on actually second. That is the Sera evening, sir.
Evening. I know.
Somehow we coordinated with Chaudhary sir also, and we tried to postpone it also, but somehow we could not adjust it.
That is fine. I think this is you can consider it as a part of Neurovascon. Curtain raiser.
Yes.
Mujumdar, your voice is coming very, very husky voice.
No.
It's clear, sir. It's clear.
Sir, my voice is not clear.
Yes, it's clear for us.
It's clear, but it's very husky and it's very sexy voice you are getting.
So we should start in
couple of minutes, sir. Dr. Paritosh is supposed to join, sir.
Hello, Girish.
I'm here only.
Yes, sir. Hello, sir.
Hello, sir.
Good evening, sir.
Good evening, Dr. Mishra, Dr. Swarup.
Good evening. I can't see everybody. I think, where is it? Is it Kishore? Is that?
No, Dr. Swarup, sir. Dr. Swarup Gopal from Bangalore.
Yeah.
Good evening, sir.
You can see,
Good evening.
can see me, sir.
Yeah, I can see few, but I see Dr. Gupta, I see Swarup, you, Girish, and Sipsankar and Datta.
Yeah.
Good evening, sir.
Good evening. Yeah.
Dr. Paritosh.
Paritosh आ गया अभी हाँ ठीक है.
Good evening, Paritosh.
The district remains the same, right? Sir, Dr. Mishra will be talking first, and then Paritosh, and then Vipul, right?
Vikas, sir. Yes, sir.
So that order remains, huh?
Yes, it's same, sir. All are here.
Yes.
Dr. John Bennett, BK Mishra sir could connect him, and the same webinar is relayed through his neurosurgical TV also, sir.
Oh, okay. So this is going through neurosurgical TV, you mean?
No, sir. We have our this Zoom link, and our YouTube link is also on. At the same time, that will go through neurosurgical TV also. That will be relayed through neurosurgical TV also, sir.
Okay. That's good.
Yes, sir. So they had some technical issues that was resolved.
No. So Shivshankar, you said you want to show some videos or something?
Yes. To start with, sir. So should we start?
Yeah, I think we should start.
Okay.
Yeah. So I think good evening. Should I start, Shivshankar?
Yes, sir.
So you will show the video first, or sir, Dr. Mishra will go first?
I'll just. So my screen is seen, sir.
Yes. So good evening, everybody. I think on the eve of Neurovascon, we are having a very important webinar, which also is the theme of Neurovascon. So we have a very august expert panel, which actually needs no introduction, but we have Professor Dr. Mishra speaking on why microneurosurgery of aneurysm should continue, and followed by Dr. Paritosh Pandey as a hybrid neurosurgeon. Dual training in aneurysm treatment is better for outpatient outcome, and followed by endovascular neurosurgery in intracranial malformations by Dr. Vikas Gupta. So, and we have eminent panelists, again, Dr. Menon from KMC Manipal, who is also needs no introduction. He is a very senior neurosurgeon with an editor of Neurology India also, and Dr. Swarup Gopal from Aster Bangalore. So may I request, I think, Shivshankar to just start with some videos and then followed by Professor Mishra's talk. Yeah, thank you.
Yeah, good evening, respected neurosurgeons and all the panelists and respected speakers. Welcome to MCNS 7th webinar, Young Neurosurgeons Guide to Clipping versus Coiling of Cerebral Aneurysms. We all know that endovascular treatment has changed the way of neurovascular practice in the present time, and now the time of debate has come whether clipping is better or coiling better, or should we be a dual trained neurosurgeon. So our world-renowned esteemed speakers will discuss the challenges, controversies, and guide us in choosing the best practices for patients with aneurysm. So when patients with aneurysm comes, as a young neurosurgeons, we are exposed to both clipping versus even coiling also. So before we guide the patient, we need to have a proper knowledge about these two procedures. And today the MCNS webinar will do the justice and clear the doubts and make us understand better these techniques and choose the best for our patients. So I'm here to start with two cases. I'll just show videos of two patients. These are just a surgical uh, CT angio and is it seen, sir? I'm not able to.
No, not seen.
No. Not seen.
I'm not seeing Simsham.
Now it's captured.
Now,
Yes, sir.
Yeah.
So the
Now-
first case is a 50-year-old male who presented with this giant MC aneurysm, which was ruptured. And the whole aneurysm was coming from one of the large MCA branch, main M2 probably, because I don't know which is bifurcation here. And there are two vessels which is coming out from the dome. So these are the cases where probably the surgery is better and it requires extensive surgery wherein we need to clip and anastomose two vessels. And probably, as per my limited knowledge, endovascular has no great role in such cases. And this is what we could do. We clipped the aneurysm and did two anastomosis for the distal vessels. And these challenging cases needs very high-end skills, as the senior neurosurgeons would be doing it routinely. And this is a DSA. I'm just showing it so that we can have a good discussion and guidance by the seniors who will be speaking about coiling versus clipping in this webinar. So this was the case, and he went ahead with clipping of the proximal neck, and we could save the vessel which was arising at the neck and anastomosed. But outcome was not that great in this case because there was an intra rupture and brain bulge before we could do a bypass to the main branches. So this is a second case, a 14-year-old girl child who presented with this giant thrombosed ICA paracranial aneurysm. And in such a child, extensive such a bypass surgery would be too risky. And this is where the endovascular makes a great difference by putting a flow diverter and can change the life of the patient forever. So this is where these are the two cases with which we'll go ahead and discuss and learn from the eminent speakers and try to understand that in this era, which is better for the patients, because at the end of the day, we all work towards the benefit of the patients. Neither we are here to defend clipping or coiling. So the best options we have to choose, and we'll learn from the speakers here. So I would request, I will stop sharing the screen and request BK Mishra sir to start his first talk that aneurysm clipping should remain, and he will guide us further. Over to you, sir.
Okay, are you seeing my screen?
yes, sir.
Yes, sir. It's seen, sir.
Okay. All right. So very, very interesting, difficult cases, Shiv Shankar, and both are complex cases and they are difficult to manage. I will come back to that later. Slight difference of opinion than what you talked, but I'll come back to that later. I'm just before I start, the people who are interested in aneurysm surgery, please look forward to the December issue of JNS Focus, which is completely dedicated to microsurgery of aneurysms, which actually I am the lead editor, and there are other co-editors are Michael Lawton, Laligam Shekhar, Rose Du from Harvard, and Daniel Barrow, all four US very, very eminent neurosurgeons. So look forward to that. We have just finished the editing, and it should be the first, I'm told the 1st January, it will be online and available to see that. Okay, now, so I have no conflict. Now, let's see what is the data, what is the evidence. There are the various randomized trials, meta-analysis. Meta-analysis is also very, very strong, kind of evidence and prospective cohort of aneurysmal subarachnoid hemorrhage. Of course, the most important one, and we changed the management paradigm, was the ISAT. We all know that, 2002. But what did it show? It showed that 1 year results, but not at 5 and 10 years. except for death. The difference was not significant between microsurgery and endovascular, mostly coiling. And those are ISAT aneurysms. You see within quotes, ISAT aneurysm. These are small saccular aneurysms, mostly of the anterior circulation. And what has happened is this thing has been, taken away from the fine print has people have forgotten, and everybody quotes ISAT for all aneurysms, which is not true. This is true for ISAT aneurysm. Even for those small saccular aneurysms, the results were only better at 1 year, statistically significant, not at 5 and 10, except for deaths. For the BARROW-BRAT trial, which was led by Dr. Spetzler, there was no difference at any time point. 1 year, there was a little difference, but then the 3 years, 6 years, and 10 years, there was no difference in the outcome. But there was significant difference. I'll come to that a little later. So, there was there was a Chinese study, Li et al. There was no difference. The Swedish study, in fact, showed the prospective cohorts of the microsurgery fared better. Now, in the BRAT, they analyzed, this is 2019 in the JNS, they published 10-year data. You see the crossover was very significant. There was a very high crossover because patients who were in the coil group could not be done. And so they had to, more than 1/3 patients had to be crossover to the microsurgery group. Retreatment was significantly better. And the complete obliteration of the aneurysms were much less in the endovascular arm. And at 10 years, there was no difference in the outcome. You can see the crossover. So this is very important because ISAT was small saccular aneurysm. BRAT took all aneurysm that came. There was no distinction. And the complete obliteration rate was much less. Now, this was 2023. This was a gentleman who was traveling to US, Indian, and he had a subarachnoid hemorrhage. And it was treated in US, 2023. So, very modern data, endovascular referral center of aneurysms. And this was a ACOM aneurysm, is coiled. And now he came to us. Now this aneurysm has regrown over a period of 6 to 8 months or something like that. So this year we operated just for if the young neurosurgeons are there, just to highlight some of the points, just to make sure that we have a wide opening of the sylvian fissure, because the morbidity in aneurysm surgery is basically because of the retraction injury, damage because of retraction, or if you are contusing or something like that. So you have to wide opening of the sylvian fissure. And when there is an aneurysm which has bled, the brain is tight. So you take all the precautions, lumbar drain, mannitol, reduce the hyperventilation, whatever. You have to have a lax brain before you start doing the aneurysm. Sometimes, Drake, as very early on, he has told that if the brain is tight, come out and go back in. That also is not bad. If you're doing some aneurysm, which is brain is bulging out, you can't do something, come back. So basically, this is just to show that you need to do wide. This has already been coiled, as I said, and this is the optic nerve on the left side. This is coming from the left side. Now the coils are coming out. You can see there. This left ICA. And then wide opening, then so we need to see everything before we can clip. Now you see that we're trying to separate, trying to find out the A2 of the right side, the opposite side. There is a bleb there, which is kind of ready to rupture. This is where the coils are there. So we are trying to separate that out. Now it burst. But no panic. If it is bleeding, that's good. So we put a tentative clip first, so that just have the bleeding under control before I come back. And then I see that this is the right ACA, this is the aneurysm there. And then again, now we dissect it out. So putting one clip is not the end of the story. That's the first, kind of to control the bleeding. That's about it. So you have suction, irrigation, a lot of irrigation. And then right ACA, you see that is because the tentative clip, then we realize that the aneurysm is, the clip is taking part of the A2. So we put a temporary clip on the left A1 and you remove the clip and so readjust. So these maneuvers are very, very important. Just putting the clip and coming out makes big problems because you haven't seen everything. Now we see that, and then in fact, there was another bleb here on the other side that we'll take care of now. You see, this is the other side. This was the coil side that was filling up, and this was not seen actually in the angiogram. So we do the ICG. Again, it's a routine now. We did it many years back, and then we realized that it's a beautiful tool, and now it's available in most centers in the country. So we see all that, and then once we have seen all that, and we see that it is complete occlusion, that also has to be seen. Now you see that because there was coils there, so we had to reinforce that, and then because we had and the artery had gone on the clip, so we put some papaverine to reduce the spasm. And we also do the fluorescein also, and the fluorescein is better in seeing small vessels in our practice, and ICG large vessels are better seen. So this is just one video to show the and if you have a doubt, again, you go back and see everything that is fine. And that then we put, because this was already coiled, we put a little bit of muscle around that clip because it was a bilobed aneurysm. And then we come out, and then I think this would also have the angiogram in this. We do a CT angio always. If it is a very complex aneurysm, we do a DS. Otherwise, routinely, it's a post-op CT angio. Let's see other evidence. Now, this was the cohort study, 2024. What did it show? Microsurgery was preferred for MC aneurysm and fissure, high-grade fissure. Treatment modality was not associated with any outcome measure. The things which did influence is the poor subarachnoid grade, higher age, and ischemic deficit, neurologic deficit, delayed ischemic neurologic deficit were significantly associated with unfavorable outcomes. So whether you did endovascular or microsurgery didn't influence. This is also in 2024, and this also showed that at 3 months, there was a difference. At 6 months, only age, admission of WFNS score remained significant predictor. So they did not influence whether you do the endovascular or microsurgery. Now, this is, you see, the risk of rebleeding always favored when it is clipped. And this is the forest plot. This is very easily to see. And the risk of mortality, high mortality, was no difference whether you did endovascular or microsurgery. That was the meta-analysis there. Now, this is a meta-analysis. Again, this was, I think, is published in journal. This is again 2024. A large number of patients and re-rupture of target aneurysms are more common after coiling and should be considered in the pre-therapeutic decision-making process. So they make a point to think about that there is a long-term re-rupture rate is higher. And now this is JNS, and this is only last year, 2024, I think, or 2025. I can't see which year, 2025. So very recent. Now, in MCA aneurysm, what they said that a microsurgery should be considered the primary approach for unruptured MCA. And we saw the ruptured ones, and this is unruptured. This is a systematic review and updated meta-analysis. It's a very high level of evidence, and this is only this year. So this is not, historical data. So there is no question microsurgery is more definitive, is more durable, but there is a higher procedure-related, at least early morbidity. So if you make your surgery less morbid, less complications, that's the way to go. So how do we do that? We do wide opening of the sylvian fissure so that we avoid the lax brain and we avoid retraction. We spare all the veins, whatever it comes. We can leave, strands of the arachnoid over the veins and go proximal and distal so that we have a wide opening. And we just saw Shivsankar showing that bypass, and that's going to stay. It doesn't matter how advanced the endovascular things are there. Bypass will be required for some of the aneurysm. There is no other option many times in endovascular. And if you have complex aneurysm, posterior circular aneurysm, base aneurysm, large giant aneurysms, skull-base approaches does help to reduce, number one, retraction, access is better, and seeing all the branches and perforates are better. So knowing there is the synergist of cerebrovascular and skull base is very, very important. Now, some of the tricks in my practice, I'll just show you. This is a clipping of an unruptured left ophthalmic segment aneurysm. This is this one. She said this is some of the problems and how to tackle that. Now we'll go to that. Now this is a dorsal aneurysm. So there is a risk of rupture, because it's a acute aneurysm. So I just don't want to miss that part. I think this is that one. Now we're just separating, there's no retractor there. We're separating the arachnoid, dissecting the arachnoid. I think this is going to, this is left ICA, the left side. No, this is a different. Okay, so this is a clinoid drilling, basically the clinoid drilling. So we need to see the ophthalmic artery, we see the neck. So you need to have drilling, good drilling, not only the clinoid, but also the optic foramen with D roof, so that the optic nerve can be, kind of retracted laterally or medially in this particular case, because the left side. And then we drill enough to get the distal ring, cut the distal ring. We first use a burr, because if you do the diamond from the beginning, it takes a hell of a long time. We have also the ultrasonic drill, but that takes a very long time. So what I do normally is a burr, then diamond, and then finally the ultrasonic, as we are very close to the aneurysm. And many times, if it is a supraclinoid ophthalmic aneurysm, my practice is to go for intradural anticlinoid drilling, as opposed to if it is a superior hypophyseal or a posterior circular aneurysm, I do an extradural anticlinodectomy. So you can do both. So now once you have drilled it enough, we get the ring that has to be cut. So there is some bone there which we are going to remove again. You see, that is the ultrasonic now, the last part, because very, very close to the aneurysm. And then we cut the ring there. Now, this is very, very important, especially the proximal, very proximal ophthalmic aneurysm. You need to have that access so that you have the proximal neck. It's very important to have that before you start putting the clip. And many of these ruptured aneurysms, I always expose the neck. Though some people expose at the petrous, I don't do that because it's much simpler for me there. And now this is the ophthalmic artery. You can see that that's optic nerve. I have de-roofed, so there is space there. I can retract it without damaging. Now the distal neck, this is the carotid artery. Now this view has to be there before you attempt doing clipping. You have everything there so that you have access. Now many of these large and giant aneurysm, they're very thick walled. And often you need at least 2 clips and sometimes more. And in spite of sometimes 2 clips, it still keeps on bleeding, as you'll see in this particular case. So first clip goes there, and you have to, of course, see that the artery does not get compromised. Now we have put another clip. Now I'm trying to reduce and see that it is all taken care of. And I had, of course, when I was doing the clip, the neck was already temporarily occluded and there was a distal clip here. Now, once I have done that, I see that clips are okay, and I put a needle to see if it is aneurysm is killed. But you will see that it is not. And I see there was no bleeding, but when I cut, I think this is the one which starts bleeding. I think this is the one which starts bleeding. Because there is some neck still there. It's not completely taken care of. I have to be sure that it is taken care of completely. That's the advantage of aneurysm clipping. So I need to see that the aneurysm the artery is not getting compromised because of the clips. Maybe this is another one. Anyway, so this is the clip there, and we see this one. Yeah, this is the dorsal. I think this is the one which bled, or this is the one I saw. Or No, this is the one we saw actually. No, this is the one we saw. Okay, this is the one. This is an unruptured. It's a very, very proximal. So I have a neck opening there, and this is the Dallas techniques. And so that this is a very wide neck. And so I have neck open, neck control there, temporary clip, very large fetal PCOM. So I put a temporary clip there after occluding the neck, the artery in the neck. And then you see that I'm sucking the artery, internal carotid artery. Suction is happening from assistant is doing that. So the aneurysm collapses, making it easier to put clips. Otherwise, very wide neck and big aneurysm, thick walls. So no clip will take there. So temporary occlusion in the neck, temporary clip in the distal ICA, temporary clip in the fetal. I'm sucking it, and now it collapses. I'm then putting temporary clip. Now, this is the one which I will show you that. And then I've taken off the temporary clip. No, this was because it was before we did the ICG. You see that we took off the temporary clip, the aneurysm is still filling. So we put back the temporary clip, and then we are occluding it. Now you see there are two clips already. In spite of that, in spite of the temporary clip, the neck, it is bleeding. So that's a good sign actually, because there's a reverse, that's contralateral circulation is good. But you have to make sure that it is taken care of. So we put extra clips there, and we occlude everything. Now we see that the artery is good. So these are the small steps, and you have to have patience to see all that before you come out, because otherwise you always repent afterwards. Now also in an aneurysm, you see this in an ACOM aneurysm. Now it's critical to see all the vessels. Now I'll just go to the area of interest. Now a temporary clip. Before that, we saw that one artery was not, I have put a permanent clip to A1 aneurysm. And then we do the ICG, we see that one vessel is not filling very nicely. So we take off the temporary clip, that's the aneurysm. This is the right A2 from the right side, right here, no temporary clip is there. That was the aneurysm clip. That was, we have done the ICG, we saw that one vessel was not filling up very well. So that is another bleb was there. So basically what I'm trying to see that you have to see everything before I'll skip, because I don't think time will permit to show you all these things. Now
Yes,
these complex ones, what is the time like?
15 minutes each, sir.
No, how much time I have left, finished, or what is the time?
15 minutes is over for.
Okay, right. So I'll go to the last, but right,
Yes.
I think let me go to this all. There's some of the things which you cannot still be done, but I think there's some simple cases also can be done. This is because flow diverter, I just want to comment about Sipsankar, you talked about the second case about flow diverter. There is a very high risk of recurrence in giant aneurysms in flow diverter. So, and especially in a child, that was a young child, I think maybe it's better to do a bypass, because the long-term, we don't know how long it is going to last, and the double blood thinner for a child, I don't know if that's the right thing. So I'll just skip that. I just want to show this is old-fashioned clipping is still relevant, and it is definitely better for MCA aneurysm, preferable and more definitive and durable for anticircular aneurysm and giant aneurysms. It is equivocal, and you need to have expertise for posterior circulation aneurysms. So before I close, we just would like to invite you all to come to the MCNS Congress, and this is along with the International Conference of Cerebrovascular Surgery in May 2026 between 14 to 17 in Mumbai. Thank you.
Thank you, sir. I think that was a very good kickstart to learn that aneurysm surgery is still there to stay, and it will, I think, gain more judiciousness in the realm of many other options. So we will have a panel discussion afterwards. So may I invite Paritosh? Paritosh is here for his talk on about the hybrid approach to endovascular surgery.
Yeah. Thank you very much, Shankar. Thank you, sir, for this wonderful lecture. We wish we could all get a lot of these kind of surgeries. So my disclosures is that nothing I'm about to say is unknown to most of the audience. And these are my views as dual trained neurosurgeons. And these are not the only truth, and there are many versions of truth. So majority of the data can be presented in different ways. Even RCTs have their flaws, as Dr. Mishra has already said. And eventually, evidence is coalesce, and often a new, better or comparable treatment emerges, which becomes the treatment of the times. Like microsurgery became the treatment of the times in 90s and 2000s and things like that, and then things change. Here are a few facts, and I will not present much data because sir has already said, and everybody knows all these things. In the short term, at least, coiling has endovascular treatment as a distinct advantage over clipping. ISAT, BRAT, and there is 1 year clinical outcome with 7% better outcome, which did not stay in there. In the long term, at least in anterior circulation aneurysms, clipping and coiling have equivalent results. And this has been shown by Sir, and many other papers have shown these. There's no point going into many of these things. What has not been shown that the one is the clipping has distinct advantage, except for a few which I'll come to there. There are other cohort and registry data as well, which show almost the same thing, that in the long term, there is no real difference between the two approaches. And there is in Medicare, other cohort data, which is there. And this data as well shows that there is no major difference between the two approaches. Meta-analysis, again, because they take most the weight of the evidence from the two randomized controlled trial data, ISAT and BRAT is much more than any of the other data. They all favor coiling in patients where aneurysms, very important, aneurysms which are amenable to both treatments. And in this age and time, with all the data, all the technique, almost 75 to 80% of the aneurysms are amenable to both treatments, both microsurgery and endovascular treatment. Of course, in posterior circulation aneurysm, even before everything, coiling had a distinct advantage over clipping, and most of the centers, except for very, very few, they do coiling before this. Again, stent in acute period increases the risk of procedure. There's no doubt in this. There is much data in this. And that is why most of these patients should undergo microsurgery if somebody requires stent in these kind of procedures with endovascular treatment. And this is the data where you can see there is peri-procedural complications are quite high, mortality is quite high if we indiscriminately use stents in ruptured aneurysms. Now the data is coming, which is better, but as of now, the data is not very favorable to usage of stents in acutely ruptured. There is another way in which you can do it. You can partially coil these aneurysms, which is called dome coiling. And then after 4 weeks, come back and complete this with stents. And that's an approach which has become quite popular in many of these things. Larger the aneurysms, higher the recurrence and recanalization in patients who are undergoing EVT, and they would require probably another form of treatment. In general, with only coiling, there is 1/3 of the patients used to have some recurrence, out of which 1/10 will have some kind of repeat procedures. However, the rebleed rates of recurrent aneurysms is extremely low. It is equivalent to unruptured aneurysms, which is a 2 millimeter, 3 millimeter ruptured aneurysms, the rebleed rate of which is extremely low. Also, the risk of repeat procedure is very, very low. Of course, cost in our country is much higher. Availability is also much lower than surgical procedure. So if we want to wait for coils to come or somebody else to come, each day has a rebleed risk, which obviates the benefit of endovascular treatment here. Most importantly, the patient acceptance of endovascular procedure is much more than open surgery. So if a patient has a choice between endovascular treatment and open surgery, an aneurysm, a run-of-the-mill aneurysm, 80% of which are amenable to both treatments, the patient acceptance in this age and time, of course, is much higher than open surgery, and there is this is not great news. Again, wide-neck aneurysm, another important set of tumor traditionally treated with microsurgery. There are newer technologies which are coming, which I'll show you later. This is a gynecologist from Gulbarga, very famous. She came with this kind of thing, and we told her that probably it will need stent. So in acute period, we would probably do surgery, and she's fine with surgery. So current scope is of neurosurgical armamentarium. In microsurgery, there are standard techniques: multiple clipping, tandem clipping, bypass, reconstruction, and then these things. There are many more devices which I'll come to later. And then there are other scenarios which are unique scenarios. What is the decision-making paradigm? Most of the Western countries are now following what is called as a first right to refusal. And in those countries, this is endovascular has first right of refusal, and then it goes to surgery. That is there in Europe, that is there in UK, that is there in many departments in the United States. Multidisciplinary meeting, of course, never works because everybody is busy, and probably whoever has the right to the patient makes the decision themselves. And then there is, of course, patient-centered decision making there. All treatment should increase both of these: patient safety and treatment efficacy. So the factors that determine treatment are the standard ones: ruptured versus unruptured, location, size, neck dome, patient factors, surgeon's experience. Clipping, of course, can clip most aneurysms. Obliteration rates are high. Equivalent results in anterior circulation: more vasospasm, less patient acceptance. Coiling, there is crossover. Obliteration, not in 35 to 40%, but there is probably 10% of them with modern technology. Obliteration rates are lower, recurrence is higher, better for posterior circulation aneurysm. So of course, these are standard ones: MCA and aneurysms with branch vessel coming out, any aneurysm which might need a stent. Younger patient probably with longer survival, and giant aneurysms with rupture where you cannot use flow diverters. These are clipping preferable. Coiling is posterior circulation, older age. But most of the anterior circulation aneurysms are equivalent in both of these. And as I said, the patient-driven decision, if there is a patient-driven decision, they will choose endovascular. And that is what has led to this massive explosion of endovascular treatment for aneurysm, so much so that in most departments, 2/3 to 3/4 aneurysms are now treated endovascularly, keeping in mind both treatments are equivalent here. So these are all decisions there. So these are various examples which we have done over the years. Clipping of the wide-necked ACOM aneurysm, branch vessel coming out, we have clipped. Branch vessel coming out, we have done bypass and occlusion, multilobulated. Go ahead and clip. This is kind of aneurysm needing bypass, wide-necked aneurysms. We've clipped aneurysms with ICH. We have clipped. Extremely tortuous anatomy nowadays with distal access catheter. These kind of aneurysms can be easily coiled, but in that time we did not have that kind of thing. Of course, basilar bifurcation aneurysms are almost always treated with endovascular treatment. Small neck ACOM aneurysms, we can easily coil these aneurysms. SC aneurysms, again, posterior circulation, coil them. Small neck ACOM aneurysms, you can easily coil them. Wide neck basilar top aneurysms, you go ahead and do these kind of procedures. What I'm trying to say is that in most of the patients who have an aneurysm amenable to both treatments, if you give a choice to the patient of both treatments, and if the neurosurgeon has the training to treat both aneurysms, most patients will choose an endovascular treatment here. But of course, much of what is said will be obsolete very soon. And there are neurotechnologies there, which is flow diverter, which has already taken care of almost 90% of the high flow bypasses. Most busy departments would not do more than 5 or 6, while even run-of-the-mill endovascular surgeons can do 5 or 6 flow diverters in a couple of months. And these are easy procedures. These are very easily done. They have great results with the technology. Of course, they have their own complications, as all the procedures have. But in cavernous and paraclinoid aneurysms, they've almost entirely replaced the open surgery, large and giant aneurysms of them, despite some concerns with vision here. So this is there. These are all treatments of pre and post. You cannot even see where the aneurysm was. The entire vessel remolds. Again, these are aneurysms which are standardly treated with either carotid occlusion or high flow bypasses, but you can easily treat them with flow diverters, and they're like magic here. The other sorry, I'll just go fast because time is less. Again, there are newer devices like web device and contour device, which is there for wide neck bifurcation aneurysms. One is like a balloon, another is like an umbrella. And these have great results, not very long-term results, but these are great results. The contour device can also be used, and web device can also be used for ruptured aneurysm, because they will not require antiplatelets, or it will not require at least 2 antiplatelets, because there is very little metal in the vessel. So these are the vessels which we have done through contour devices, MC aneurysm with contour device, all these aneurysms which are contour device. And these are easy procedures to do. Long-term results are still awaited, but 3-4 years results are not bad. Again, there are other things like pulse rider, PCONUS device, neck bridging device, barrel device, neck bridging device. All of them are for the last frontier of the endovascular treatment, which is wide neck bifurcation aneurysms. So patient with aneurysm, it is safe to coil. Is it complicated clipping or simple clipping? Will it require complicated hardware? Will coiling be durable? Will it need retreatment? All of these are done. And these are the 3 approaches which a person in a dual training would probably do. What is the third one? Understand what is safe and effective for an individual patient and offer him or her the choice. Of course, simple is better. Clip or coil can be equivalent in results. But I want to say a few words about how aneurysm surgery will die. And it is not because endovascular surgery will become more and more popular, but if the neurosurgeons themselves will refuse to learn it, then what will happen probably is they will have lack of control of patient inflow. I'm not saying it's very senior neurosurgeons like Dr. Mishra and other people, but in most of the departments across the world and in the country itself, there are patients who are admitted under critical care, and they are become the great gatekeepers. Or if the neurologists know endovascular treatments, then they become the gatekeepers. So unless the neurosurgeons are the gatekeepers of this disease, they will not become the decision makers here. And if they cede space to radiology, neurology, and critical care experts, and if we do not perform the endovascular procedures for 2/3 of the patient at least, someone else will. There's no vacuum is here. So what I want to say is that we can only ignore this endovascular treatment at our own peril. Even though open cerebrovascular surgery is brilliant, endovascular surgery is brilliant, and it is another form of treatment. Every specialty has its changes. We cannot say today that I will do skull-based surgery without endoscopic skull-based surgery. Similarly, no one can say that I will do spine surgery, but I will not do minimally invasive spine surgery. These are just another form of treating the same disease. There is no competition. There is acceptance, training, and performing safely. Time has not stopped for anyone. It will not stop for open cerebrovascular surgeons. The change is inevitable. The approach of clipping versus coiling is a wrong approach. And the only way the younger neurosurgeons will have a very big seat on the cerebrovascular table is if they co-opt the endovascular techniques in their own treatment and start doing it, so that they continue to stay gatekeepers and decision makers in this and not cede space to other specialties. As high flow bypasses has already almost gone to the relics of the neurosurgery with flow diverter, endovascular techniques has already replaced in most of the countries, will replace at least 2/3 of open surgery for ruptured aneurysm. And let us not allow aneurysm surgeries to die. And it will live only when neurosurgeons learn both techniques. With this, thank you very much for your kind attention.
Thank you, Paritosh. I think that was a very balanced view about clipping versus coiling, which is indeed it is a great dilemma, and I think it will take a while till the final verdict is out, maybe a few years more. So with this, we go to our third talk with Dr. Vikas Gupta from New Delhi. I think we will talk on endovascular surgery, a key component of neurosurgical practice. Dr. Vikas Gupta, please.
Good evening. Am I audible?
Yes,
Yes,
you are.
sir, you're audible.
Good evening, Professor Mishra, Paritosh, Gopal, of course, Shiv Shankar for calling.
Thank you, sir.
As both the masters were speaking, I managed to edit my presentation to avoid duplication, but bear with me if there are a couple of slides which are overlapping. I was, in my conversation with Dr. Shiva Shankar, I was told that I have supposed to give a perspective for neurosurgeons in early areas of practice, especially in Tier 2 or Tier 3 cities. Of course, what Professor Mishra shows is actually a Picasso's world. It is difficult to believe that many people or majority of us can replicate that, but certainly it has a beautiful demonstration of microneurosurgery. Why Dr. Shiva Shankar chose me, I don't know, but why I agreed that I know. Probably I was one of the very few who started with carotid punctures in 1995 and continues to be in both the streams of science till today. Starting in GB Pant, first neurosurgeon after Professor APK, Professor Karapurkar, who got a neurocath lab in private sector in 2005. I went to Zurich for a fellowship. Why? I can come to it if somebody wants to know. I was the first one to get access to deliver what is required, and your required outcomes are possible. My position is very clear. I agree with both of them that the microsurgical clipping will and should continue. Dual trained or hybrid neurosurgeons are the need of the hour, but I will come to the position of complete neurovascular surgeon. What is that? Controversy remains. I think I should not waste time on this. I will try to edit them. Everybody knows about this. I'll try to. This is a graphic form of both the speakers have said. I will not spend time on this. Now, Indian perspective. More than 80% of the aneurysm we see, at least what I have in my experience in so many years, are bled. And whatever the modality you treat, vasospasm is a real beast. It is responsible for morbidity and mortality. Endovascular therapies for vasospasm, even if repeatedly you have to do it, they save lives. Do surgeons regularly do a DSA post-clipping? No. I don't think everybody rigorously agrees to do a DSA post-clipping. People do have their reservations. Some will say there will be complications. Some will say patient cannot afford. I will not go into that. However, coil embolization patients will almost always undergo a follow-up DSA as per respective institution's policy or individual's policy. In our context, evidence of completely occluded aneurysms in both modalities across the country or across the institutions is not conclusive. Post-procedure DSAs are not done. That is my understanding on last so many years. In our early days where we started, and what is my audience, which I was told to address, was young neurosurgeons in Tier 2 or Tier 3 cities. We had a basic CT scan, which did not function in the night. And so, as I mentioned earlier, we did carotid puncture. My teachers were respected late now, Professor Sushil Kumar and Professor A.K. Singh. After a day's labor, they used to ask only two questions. What is the location of the aneurysm, which direction it is pointing, and which is the dominant artery of the two. So that was the job of person who did the angiogram. Incidentally, around that year, 96, 97, Professor A.P.K. Sir's stint in Delhi was a blessing. He frequently came over and starting teaching us femoral catheterizations. Other contributors to my generation of surgeons were Professor N.K. Mishra and Dr. Shakir Hussain. Tuesdays and Fridays are our neuroradiology days. I used to get assigned to majority of these days by default because others were either too smart to go to the OT or I was too junior, whatever that may be. So in a typical day on Tuesdays and Friday, after doing the angiogram, I or many among my colleagues used to carry the bunch of films to Ames or Apollo on our own scooter with a broken headlight or whatever. So others lost interest, but there is where I got interested. Why I'm saying this is because I was told this is for the young neurosurgeons. Whereas Professor Mishra and Professor APK sir had cath labs in the day, we could not attend. But Shakir used to get cath lab at the night in various private hospitals. After our routine work, we used to visit him. And even he used to take long hours for even a DSA. There was a certain learning curve for everybody. There were early days, cardiac cath labs, it used to take time. Lab technician and nurses all used to play truant because carotid procedures are usually short, half an hour out. So we learned to operate machines and assist each other. That is how we became interventionists. So my message to young neurosurgeons and for endovascular therapy is learn and spend time. Do not use shortcuts. Now, FNB neurovascular interventions of national board is available since 2019. I was a part of the specialty board for this intervention. But sadly, I am noting for last 6 years, number of neurosurgeons even appearing is negligible. So as Paritosh tried to point out, not only clipping, but maybe even coiling or endovascular procedures may be out of our reach if we are not formally qualified. SNV is also awarding fellowships after a due entrance and exit examination starting. So these are all for 2 years. Now, the guidelines for endovascular therapy for aneurysms, theoretically, every aneurysm is eligible for coiling, as Paritosh very beautifully illustrated. But I prefer clipping when there's a large hematoma. No sense in Indian settings because you sooner or later will have to evacuate. MC allocation, usually I do not offer endovascular unless patient insists. Still, I try to dissuade them. It is not easy. But cost is the elephant in the room. Majority of clipping is done because people cannot afford coiling, and my number remains equivocal for both. Why EVT for neurosurgeon is relevant, important that they should learn. Approximately 30% of the patients will need EVT or shunt later on. Decompressive hemicraniectomy may need to be done by a neurosurgeon. When a disaster occurs in a cath lab by anybody else other than a neurosurgeon is called in to handle it. I feel it is better that a neurosurgeon is best professional for endovascular techniques. Basic requirements, adequate certified training preferred for 2 years, cath lab with at least roadmap and 3D rotation reconstruction capabilities, adequate number of pressure bags for infusion lines. These are very small things, but they matter in the outcome. I have seen people compromising in this in the periphery. That is why I mentioned. A confident and a patient anesthetist who can manage in the cath lab and do it at your comfortable time and pace. In a shared cath lab, pressure of cardiologist of a primary PTCA will always remain. Check all the material yourself before starting the case. Both diagnostic available in the hospital and hardware sourced from the vendors. I will prefer to see them deal myself before starting the case. Along with your preferred options, do keep a backup for any kind of exigencies. You will gain entry into the cardiac cath lab now. Times have changed. 30 years ago, we were not allowed. Now the economics will force them. DSA should be as safe as an MRI. At least that should be your motto in the mind if you cannot write. Do not leave sheath or groin dressing to the paramedical. Do it yourself. Believe me, I still do it. Do not leave the hospital or the patient without removing the sheath and checking the groin. Initially, hold workshops. Request proctors to hold your hand. Despite adequate training, aim should be no procedure-related complication in any kind of endovascular procedure. To be successful in any small town, because complication travels faster than your success. My take, over the years, by virtue of doing both modalities, my spatial orientation of anatomy in microsurgery has become much better. Especially after 3D recon, if I have to clip, my dissection is much cleaner. I have much fewer intraoperative ruptures. Mental fusion of an angiogram and microscopic vision has evolved over time. I know how long the ACA will be, where to look for, which direction to look for. And most importantly, as I mentioned earlier also, we are very, very high index of suspicion for vasospasm, and intervention for VSP, I feel our mortality has drastically reduced. Of course, vasospasm cannot be conquered, but if detected in time and if it is responding, certainly the mortality and morbidity is reduced. Setting up a neurosurgical or neurovascular center in a tier town is a challenge, but not impossible. Policymakers some time ago, few years ago, made a mistake to make far too many neurosurgeons than are required. My advice to young fellows is do not float to metros to become junior asset consultants in corporate hospitals, at least in North India. In the last 15 years, at least I have not seen a roadmap for my junior to become a senior consultant. They leave in frustration at the age of 45 to smaller towns. Then why not start in the smaller town? Though this webinar is for aneurysms, but I should mention in the last couple of slides, there is a huge burden of stroke. They need immediate intervention in case of a large vessel occlusion. They have no time to go to XYZ metro or branded hospital. Too many trained professionals are needed for stroke. Current number of trained neurosurgeons, neurologists, and radiologists are simply not sufficient. Carotid disease is another large chunk of population which needs attention. And diabetic pandemic, as we believe, will need more and more people to do it. And after spending 25 years, I can say that neurosurgery is in crisis. We have produced too many neurosurgeons who are competing with each other for the same pie of work. Inadequate facilities for these people, shrinking scope. Spine is being taken over by orthospine surgeons. A corporate hospital a couple of years ago mandated me to do a laminectomy for spine tumor surgery. Spina bifida and VP shunt are being encroached by pediatric and plastic surgeons. Skull-based endoscopic surgeons by ENT surgeons. That is a fact of life on the ground at least in Northern India. I feel a complete neurosurgeons need to be trained in neurovascular interventions in the university curriculum, followed by a formal fellowship. My humble appeal to all the teachers, leaders of our profession to take initiative at institutions, universities, national boards, National Medical Council to include both hemorrhagic and ischemic strokes in the formal syllabus. My advice, again, concluding, go where you are needed, not where you want to be. Delhi, Mumbai, Bangalore, Chennai, any other is dominated by big corporates. They earn for PV funds for shareholders. Their aim is to reduce cost. And in the healthcare, the only way to reduce cost is income of the doctors and nurses. You can only be an employee. And employment is not a security of salary, but a lifelong poverty. Our profession was meant to be independent. Smaller towns, you are needed there. You will get recognition and respect. You are likely to get access to a cath lab easily. Negotiate better with the implant companies. Make the procedure cheaper and affordable. Probably you will get higher volume of patients. Subsequently, you can do whatever you are. I have a permission of one of the interventionist colleague, Dr. Rahul Kumar, who is settled in Patna, one of the notorious towns even now. He has built one of the best neurosurgical centers anybody can think of. Icono biplane cath lab, first in the Asia, which runs into about 15-20 crores. These kind of CT scans, I asked him in the morning, Dr. Shiva Kumar, Dr. Sanjay Gupta in Moradabad. Dr. Anup Singh in Azamgarh was the first one to order Kinova microscope somewhere around 10 years ago, which was worth 7 crore at that time. So there are innovators. This is the setup which Dr. Rahul Kumar has created in the last 12 to 20 years, 12, 15 years, since 2012, 13 years. So I think, thank you for your attention. If I found it useful, any questions, please.
Thank you, Dr. Vikas Gupta. I think you have given a very realistic view of what our country needs today. Obviously, there are two aspects which have not been touched upon, which will have impact on our treatment modalities, that is insurance and medical legal. Because who does what and how he does, and the insurance companies are going to be a major factor in deciding the treatment. As you mentioned, ortho spine surgeons are asking you to do a laminectomy for spine tumor, but I'm sure in the future insurance companies are going to dominate, as we are just following the US, and times to come with corporates trying to take over. It is going to be another dimension. So with this, I think that all the speakers have been very good and they have set the stage. I would request all the speakers to just look at the chat box and answer the questions so that we reduce the time. And may I ask now our two eminent panelists, Dr. Girish Menon and Dr. Swarup Gopal, to give their views and about the speakers and their talks and how to go forward. Thank you. Dr. Girish Menon, to go first.
Thank you, Dr. Dattatre. Thank you, all the speakers. I guess we got a balanced view about all the two modalities. Look, can you hear me?
Yes, you're audible.
We can hear you. We can hear you.
Yeah. So just to set the ball rolling for some more discussion, I just wanted to start with Dr. Paritosh. In fact, Paritosh, you said the only way that neurosurgery could survive would be if neurosurgeons start doing both. But I would, just for the sake of argument, I would say it would appear to be a contradictory argument, because if he knows to do both, and the natural tendency would be to coil first. And when that happens, the chance that somebody starts doing, learns clipping is going to come down further. If you look at the ISAT trials, one of the critics of the criticism of the ISAT trial was that most of the coiling was done by experts, whereas clipping was done by the residents in training, and that's why the outcome was not that good. But now if you say the system, the scenario has reversed. Now clipping is done in very few places, and generally it is done by people who are experienced. So the results are kind of good in the hands of experienced people. And the general shift towards coiling happening, how do you think young neurosurgeons are going to learn clipping?
I think the situation is not what it was 20 years ago. 20 years ago, when I was doing my residency, there were like 7, 8, 10 centers which were regularly doing clipping. Now, every district town has places, neurosurgeons who are doing clippings within 5, 6 years of their training. So I think we are producing better neurosurgeons, better trained neurosurgeons. And most of them, including Shiv Shankar and his friends, are doing very high quality open vascular work in even smaller places, let alone large cities. So
yeah, just for argument's sake,
what I'm trying to say,
Shiv Shankar, do you have an endovascular surgeon in your center?
We have a cath lab and setup, sir, but we don't have a full time because we
Yeah,
are in between Mumbai.
that's what I was telling Paritosh.
no, what I'm trying to
Shankar
say
is
is that
able to do this because there is no endovascular surgeon there.
not quite. I mean, there are people who are doing, if you come to the SNVA, there are people who are doing all kinds of open vascular surgeries in even when there are things. What I'm trying to say is that if the neurologist or the interventional radiologist get a patient of aneurysm, their only goal is to treat it endovascularly, come what may. And you will see this in most endovascular things, that their goal is to not treat the aneurysm. Their goal is to treat the aneurysm with endovascular. But if a hybrid neurosurgeons know both of them, they will judiciously treat the aneurysms which are to be treated better treated open vascular with open vascular surgery. And that is how the whole scenario will change. But if we leave the gatekeeping to neurologists and interventional radiologists, as most of the EU and UK and other places have been done, then you will be left with 10 aneurysms, 12 aneurysms to clip in most centers, which is very, very inadequate. So only if you learn both of them, and of course, if this is only if you want to dedicate almost 2/3 of your practice to neurovascular. If you're doing everything, that's a completely different matter. But if you want to have a serious seat at the table of the cerebrovascular surgery in the next generation, it is imperative that you do both of them.
Girish,
Yeah.
let me add, see, this conference itself will tell you the way things are going. Two of the speakers are hybrid neurosurgeons, and one of the other chairpersons is also hybrid neurosurgeon. So I think putting all the arguments together, I think it is good for a neurosurgeon to be able and adapt at both technologies. That is going to be the things to come, ignoring all the statistics that was very well put up by Dr. Mishra and Dr. Paritosh, and also a very philosophical note by Dr. Vikas. So what I'm trying to say is, my dictum is very simple. Any surgeon who's able to treat a particular disease, he should be able to manage all the complications ensuing. And who is the best person to do that? I think a hybrid or an endovascular and a dual trained neurosurgeon is the one who's going to be able to do that. Now, as Paritosh said, you can't have a blanket rule for all patients. So what we try to do is we individualize. Now, on the other side, where Paritosh said young patients who would prefer clipping, I've had situations where an young patient, a girl with an aneurysm, absolutely refuses surgery for various reasons, including getting married later on. So they would hinge more on doing endovascular. So each situation you would encounter where you would individualize the decision making based on that particular patient and what treatment suits that patient. That is the best way to go, because you can't be sitting with them talking about statistics. And Vikas would also tell you the same thing. And on the other side, in our theater, of course, we are in a big city. Our endovascular suite is part of the neurosurgical theater, and we control the biplane cath lab, and we have the theaters along with it. And the good thing about it is, instead of allowing other specialties to encroach upon, the biplane cath lab is a neurovascular domain. We use the lab. If the radiologist wants to do it only for peripheral work, we would let them come and do it. So that's the way we dominate things in our place, because we hold the neurovascular domain with us, and we are the gatekeepers for everything, not the ICUs or any other specialties. Now, coming to the cost aspect, of course, endovascular is, of course, costly. And when you keep on doing radio angiograms for them repeatedly, the cost goes up. So what we've done now in the last couple of years, we've switched most of our diagnostic work to radial. So we are doing most of our diagnostic work as radial procedures, where the patient comes in the morning and by afternoon he's home. So you don't have to spend the whole day. Your costs are less, and he just walks out of the cath lab after the angiogram. So all these modifications you have to do to entice the patient, make it more safe. And there's no doubt, even in the West, endovascular surgery is a little more expensive. So you have to accept it. But the way things are going to go is dual trained neurosurgeons are going to be more and more, and you have to compete with the rest of the world. I think with the patient being the center, the maximum rapport with the patient is going to be a dual trained neurosurgeon rather than multiple specialties being involved. Thank you.
Oh, my Paritosh, and no, I think I could not make myself clear. I was wondering a scenario where the team is the gatekeepers are a neurosurgery team, but I was wondering, in like you do coiling one day and clipping the other day. Instead of that, you keep concentrate on coiling, and your colleague neurosurgeon concentrates on clipping. 10 years down the line, he would be an expert in clipping, so that he can do complex ones. So I was not. That's what my argument, my point was. Instantly, like Shiv Shankar is now doing quality work in anastomosis and complex aneurysms. But if he were to do coiling today, clipping tomorrow, I'm sure he wouldn't be able to do this kind of quality work.
I
So-
disagree. I disagree with this, because neurosurgeons in the present time, and if you see in India, neurosurgeons are doing DBS, neurosurgeons are doing open skull base, neurosurgeons are doing complex spine, neurosurgeons are doing endoscopic skull base, neurosurgeons are doing all kinds of procedure. So what is so special about endovascular work that they cannot do or they cannot learn in endovascular? Especially if they want to dedicate 2/3 of their practice into this thing. Vascular surgeons, peripheral vascular surgeons do this all the time. They do open one day, endovascular the other day. I mean, it's not really something that complicated that you can only do one at a time. You can easily do both at a time if you are well trained. And then I completely disagree with this paradigm that you can only do one thing at a time, because I mean, people who were doing open skull base all the time have now shifted to nose, and they're doing brilliant work. It's just a matter of training. And if you train yourself well, there is absolutely no reason why you should not do. And you must do. There is otherwise, the aneurysm surgery will not come to most of the places where the aneurysm, where there are trained interventional radiologists or neurologists there, because they will. Because they will.
After certain numbers, I think you become adept at both the techniques. That's what Paritosh was trying to say.
Absolutely.
Just wanted to ask Dr. Mishra in that same vein, sir, how do you convince your patients for surgery in this era of predominant endovascular surgery?
Yeah, no. The numbers of open surgery is definitely coming down. There's no question about it.
How do you convince them?
No, young
For
patients,
surgery.
no.
It doesn't need to convince people.
Paradoxically, no, it's not easy. Paradoxically, the more educated people, they agree for clipping rather than the people who are not well informed. As for a young person who they are very good, I mean, well informed people, family, they would agree for clipping. And of course, the people who cannot afford, they will go for microsurgical clipping because they can't. That's a different issue. But people who are not well informed, it is much more difficult because brain open karne ka nahi karne ka kadam. It's not easy. So numbers have definitely come down. I mean, I'm not a big fan of the concept of hybrid training, but I think Paritosh has made a huge point. I mean, that's the only way you can keep the beast in your team. That otherwise it is going to go away. That's correct. I mean, I agree with that. I'm not a big fan of a hybrid neurosurgeon, but like he said, everybody is doing everything. But I don't know whether that is the way to go forward, but that's the only way to survive. That is no doubt about it.
Sir, educated patients also might go for coiling.
No. It is, no, appropriate patients. I mean, of course, the patient has in a young patient, or and who has, for example, an MCI aneurysm, or a patient who has a giant aneurysm, they agree
They
with
would understand more.
Yeah.
Yeah.
May I add another perspective into this?
Yeah, sure.
What is important is for a hybrid neurosurgeons, or whether you said clip in one day or coil one day, there needs to be adequate number of cases per year to maintain the dexterity of the surgeon. Anybody who is doing less than X number of patients, probably is unsafe. If he is doing almost equal number of coiling and clipping, his hand-eye coordination is same, his microsurgical skills are same, it remains intact. Why not? If you can give a good outcome in either, why not?
But I think what Girish said, the fact remains. If you take the who's who of microsurgery of aneurysms and who's who of the endovascular, each one is either one of the. I mean, there are very few who are at the pinnacle of either both. I can't. I mean, in the international circuit, I'm talking. Of course, I mean, some of Paritosh is doing very well. I mean, Swaroop and Vikas, these people are doing very well. There are many people in India are doing now. Now in Bombay, there is a lot of people who are doing very good work. But if you see the talk of the top, kind of international circuit, it is either he is an endovascular guy or he's a microsurgical guy. So I think that point you cannot shy away from that point.
I agree with you, sir, completely. But what neurosurgeons want to do is not to treat the 10% of the most complex aneurysms, but they want to treat 90%.
No, won't it become like that? When you have an equipoise, when you given an aneurysm, Paritosh, given and Dr. Vikas, given an aneurysm, and when you have an equipoise as to which is better, or you know that both are better, and you have coiling, which is an easier and shorter procedure, you yourself admitted, and I mean, literature also suggests that the outcome long term, the immediate outcome definitely better for coiling, and long term outcome is equal. which indirectly suggests something in favor of coiling. So how do you break that equipoise and decide in favor of surgery? How do you convince yourself for surgery in a particular patient?
Now, to Girish, apart from the scientific part of it, believe me, on the ground, in the practical reality of life, majority of the time it is a cost. Right? I know that a patient cannot afford. I always tell them, don't sell your home, don't take a loan. Treatment is possible. We'll clip it. It's equally good. But some people are equally adamant on clipping, coiling. That whatever is to be done, we don't want a scar. We don't want to get the skull open. So sometimes the clinic, very few times what you are saying is equipoise. That equipoise for me is posterior circulation. Posterior circulation, I will certainly offer coiling first or embolization procedure first. But otherwise, I am open. MC, I am very reluctant to offer endovascular. Very reluctant. I will try to convince them 2 times. Please consider open clipping. It is much more elegant, much more easier, much more durable, much more riskless, less. But often, more than anything else, it is a cost. That's a fact of life.
No,
And that probably answers Professor Mishra's question also, that why the people are hybrid in India, because we still have to earn our bread. We just cannot say that I will refer every patient to a surgeon and every surgeon will refer every endovascular patient to me. So we have to keep a balance.
Although this debate is about aneurysm surgery, because just like you said, we are all in the era where at NIMANS we used to do direct carotid puncture in our residency days. But apart from that, the other conditions, the joy of endovascular neurosurgery is, for example, you're treating a high flow CCF or a dural AV fistula. There's lots to endovascular neurosurgery apart from the aneurysm. That's beyond the scope of this debate. But the joys of doing endovascular is much more there because you're able to treat a wide spectrum of diseases.
Oh, apart from MC aneurysm, as Dr. Vikas told, just one short question to Dr. Swaroop and Dr. Paritosh. Which are the other aneurysms that you would consider for surgery, apart taking away the cost factor?
Well, we do both. I mean, Paritosh also does both. We judge by the situation, for example, branches arising from the neck or a very large atherosclerotic aneurysm, or for example, a giant fusiform MCA. All those are ideal candidates which no endovascular person can do. You have to do a bypass. So those are the situations straight away you would go for a bypass.
So only bypass, the situations where bypass is required is the only instance, other instance where you would consider surgery?
Yes, and of course, the cavernous segment aneurysms nowadays, most of them can be tackled with a flow diverter. But like Vikas said, affordability is the key issue. If they can't, then you have to go for a bypass. So you could do both if required.
So is the take-home message that apart from complex MC aneurysms and aneurysms where you require to do a bypass, all other aneurysms, the first option should be endovascular?
No, that's not the message at all. I think my message is individualized based on the situation, like Dr. Mishra said. And of course, you have to be balanced in choosing. And Paritosh showed a lot of slides, the decision-making tree. So that is what is more important because you can't be speaking statistics to the patient.
And large hematoma.
Yes.
In case there's a large hematoma, I will not prefer coiling. I will still like to drain the hematoma.
I think most of us who do both of them have a gut feeling of what is simpler in this particular patient.
Exactly.
Probably do that thing or turn the patient to that ways, and that probably remains 2/3 endovascular and 1/3 open surgical vascular. But if you go to an interventional neurologist or interventional radiologist, they will have 100% thing. And like if you see Medanta or other places, they would clip probably 2 aneurysms a year or 3 aneurysms.
Not even 2.
Not even 2. So that kind of situation only happens when the gatekeeping is done by somebody else. And that is a situation that will happen if we do not get into this business.
Yeah, I think that depends on the local scenario. And unfortunately, the gatekeepers vary depending on the scenario, local scenario.
Right.
So there's a good comment by Dr. Yogen, but there, sir. Coiling put the whole system of circulation into a risk by catheter, while clipping is purely extracellular surgery. So which one is minimally invasive?
I don't know what he means, but I think there are femoral complications, there are carotid complications, but those are very, very, very rare.
Very rare. The modern hardware is extremely good,
Very rare.
and all these are extremely unheard of. If you do a good technique, if you're trained well, there should not be any problem at all.
I think
Complex arches, tortuous vessels.
the more important thing between difference is you are occluding the, I mean, if you're doing a proper aneurysm clipping, the aneurysm is dead for good, right? Whereas all the devices, whatever you have, the coil, the web, the kind of flow diverter, the recurrence is definitely an issue. There's no question about it. What Paritosh said and the literature does agree with that. The risk of rupture is not very high, but depends on how long are you following up and what is the follow-up rate and whether the patients are getting followed up there. Now, the more referral, I mean, more kind of center, which is the high-end center, referral center, they lose more patients for follow-up. I mean, the patient will not go back to that follow-up. He'll go to some peripheral center or he will die. In India is notorious. Follow-up is so notorious. I mean, how many patients will come back for a routine follow-up like Dr. Chaudhary Kishore talked about it? It's a routine follow-up. How many patients will have the affordability, the means to come back for follow-up? I mean, with number of patients come with a residual aneurysm, they have a sense of, false sense of security. I think that is more problem. I don't think, I don't agree that the catheter will be more invasive than clipping. Clipping is definitely more invasive. There's no question about it. And putting a catheter, competent hands, the risk is there, of course. It does happen, but it's much less compared to open surgery. But the definitive treatment is, there is, I think all across every series, including the ISAT, where only very simple aneurysms were treated, the recurrence rate was higher. I mean, the retreatment rate was higher. There's no question about it.
No, that is very true, because what Girish said also, I was at an ISAT center when it happened. Both the radiology consultant and the neurosurgery consultant would come and see the scans, whether it is suitable for both clipping or coiling. And then if it's suitable for clipping, the neurosurgery consultant would go away and the residents would do the clipping at night. So obviously the results were extremely skewed and disappointed. But I think that's to debate on. But what Dr. Mishra said, long-term results after a clip is unquestionable. There's no doubt about it.
I think Shivshankar,
Yes.
it's a very good discussion, and I think maybe we have arrived at something, but
Yes,
a lot of things to go forward from here. And thank you. I thank all the speakers and the panelists for a very good talk as well as the discussion. So I hand it over to Shankar again to thank the speakers.
yes. Thank you, sir. Sir, if you see, the most of the speakers and panelists are at least on 25 to 30 years experience they had. And probably you, many of you have started their training when they used to do carotid puncture and all. But we, the younger generation, have not seen those endovascular procedures being done while we are pursuing our neurosurgical training. Probably GB Pant in India has a dual training, and not many of the centers where when we are getting trained for neurosurgery, and many younger neurosurgeons across India. So we exactly don't know what happens with the endovascular treatment per se. There was no debate at that time when we are learning around 10 years back. But what I believe is nowadays the number of aneurysms being clipped has come down significantly in all the institutes. And many of the younger neurosurgeons who are pursuing their neurosurgery courses and those who have passed out, their keenness to learn the aneurysm clipping surgery has come down. And it is another beautiful, intricate procedure. This not only teaches us the clipping, but it gives us a very good situational awareness, how to handle the rupture when it happens, and even the fine dissection of the arachnoid, separation of the brain vessels, and handling the most delicate part of the brain. So this procedure itself, the clipping and the bypass, they demand a very high surgical skills, precision, and this can be honed only through the experience and a great dedication, and it requires really good amount of time, and we need to follow the seniors like the giants who presented their experience here. So most of the juniors are not following for the clipping or bypass. But over a period of time, if I look now for the next 15, 20 years, we don't know exactly what is going to happen with the child. What I showed in the beginning, who underwent flow diverter, what is going to happen with her over the next 15, 20 years, the time has to tell. So such cases, probably if they require surgery, there will be very few neurosurgeons left, as Dr. Paritosh very well told, that the clipping is going to die because the neurosurgeons are not taking up clipping. So if there are very few surgeons, then the clipping will really go down. So I urge all the young neurosurgeons that we should follow the seniors. And at the same time, when we are embracing the change in neurosurgery about endovascular treatment, we should also learn the clipping. The art is probably not going to die. And all these anastomosis bypass, this we record not only in aneurysm or vascular cases, but also in some complex skull base or any other tumors or any other surgeries where we have vascular injuries. We need to learn to manage those vascular injuries by either suturing or handling the vessels and dissection. So it is quite crucial to continue clipping at the same time, try to learn the endovascular part of also and know about it. And today's webinar did a great justice to the topic that we wanted to guide our younger neurosurgeons across India. Almost around 60 were attending this webinar through the Zoom meeting, and around 20-25 through our YouTube channel, and even around 30 plus from the Neurosurgical TV by John Bennett. So it was quite successful, and we take home a good message from all the seniors and the speakers and panelists. Thank you very much for a wonderful discussion of today.
Thank you.
Thank you.
you.
Thank
Thank
you.
you.
Good night.
Thank you, sir. Good night, sir. Thank you.
Thank you.
Bye.
Good night. Thank you very much. Thank you.
Thank you.